Today we'll be dealing with the hypokalemia, that is the serum potassium value of less than 2.5, so 3.5 milliequivalents per liter. So hypokalemia, as I told you, is defined as the plasma potassium that is less than 3.5 millimoles or milliequivalents per liter. So it's a very common electrolyte disorder. If you see in a medicine ward or in any ward emergencies, it's a very common emergencies for the.
If you're a business owner, then please.
In every day-to-day practice, we are going to deal this hypokalemia very commonly. So whenever you see that your patient has the hypokalemia, the first step is always to determine whether an emergency is present or not. This is a very, very important and the first step. It is not like whenever you see hypokalemia, just go on thinking about the cause. The cause comes next. The first comes the emergency. So if the patient is having arrhythmia, first treat the arrhythmia, treat the potassium deficit, then look for the cause. You cannot just wait for the cause to appear and the patient to recover by treating the basic cause. It's not going to happen. You need to step in right away in managing the hypokalemia in emergency issues. Why this is emergency? Because this is a very important in causing the cardiac arrhythmia and the muscle weakness. Both are the life-threatening issues. The cardiac arrhythmias, the patient can die in front of you within seconds, and the muscle weakness, if at all it is involving the respiratory muscles, the patient may need enough the mechanical ventilation. The patient becomes ventilator dependence for some time. So this muscle weakness is a abnormality of the hypokalemia, which is being directly correlated with the potassium level. That means more drop in the potassium level, the more is the muscle weakness the patient is going to experience. Whereas this cardiac arrhythmia may not directly correlate with the plasma potassium. What does this mean? This means even with very mild hypokalemia, patient can have the cardiac arrhythmias in some predisposing patients. Like if the patient already have some organic heart disease, or if the patient is on antiarrhythmic drugs, and if the patient is on digoxin, even a mild hypokalemia can cause the cardiac arrhythmia. Whereas in some patient, even if the potassium is severely low, may not have any cardiac arrhythmia. So the cardiac arrhythmia is a emergency of hypokalemia which may not correlate with the plasma potassium level. Irrespective of the plasma potassium drop, your patient can experience cardiac arrhythmia. Sometimes you may not have any significant past history. If the patient has a scar in the myocardium, this might precipitate the mild hypokalemia to have a serious arrhythmia in your patient. That's why this becomes the life-threatening entity. So whenever your patient is coming to you with the hypokalemia, the first thing and the foremost thing to do is ECG, rule out the cardiac arrhythmias. If at all there are arrhythmias, just bring the potassium above 3.5 before doing anything further. So in this class today, we will be dealing how the hypokalemia occurs, what are the causes of this hypokalemia, and how to evaluate for the cause of this hypokalemia and how to manage this hypokalemia. So before going into this discussion about the hypokalemia causes, we need to know some basics about the physiology of the potassium handling in the body. So this majority of the potassium, that is the amount of potassium in human body, total potassium is 55 milliequivalents per kg. This is an important number. It's better if you remember this. This is going to help you in the future also. So the total amount of potassium in the body is 55 milliequivalents per kg. So majority of this, if you see, is situated in the intracellular compartment, 95%, whereas only 5% is situated in the extracellular compartment, which is just opposite to how the sodium is distributed in the body. As sodium is predominantly extracellular, the potassium is predominantly intracellular. So this intracellular and extracellular movement of this potassium is usually occurs constantly during the body. So this is called a transcellular shift of the potassium, and this is one of the first and foremost important thing in handling the potassium, that is movement of the potassium across the cell membrane. We know there is a channel, everybody of you know this channel by the physiology, sodium potassium ATPase, a very, very important channel. So which acts against the concentration gradient. That Means it moves the sodium outside and 2 potassium inside. This is a very, very important thing. So there are some channels which affect, some drugs or some conditions which are going to directly affect this channel, altering the potassium in day-to-day life. For example, there are some aspects which increases this sodium potassium ATPase pump, like insulin. Insulin is a agent, whether it is an endogenous or an exogenous administered insulin, both are going to increase the activity of this sodium potassium ATPase, causing potassium to move inside the cell. So whenever you give patient insulin, there is sudden drop in the potassium may occur due to the intracellular shift of the potassium. And similarly, the beta adrenoreceptor agonists, or in fact any stimulation of beta receptors like sympathetic activity, is going to cause the intracellular shift of the potassium. And alkalosis can also cause the shift of this potassium into the cell. The acidosis is an opposite to that, which causes an extracellular shift of the potassium. And alpha adrenoreceptor antagonists, this is a very, very important thing. The beta receptor agonism is going to cause the hypokalemia, whereas alpha receptor antagonist causes the hypokalemia. We have got significant amount of importance for this particular transcellular shift, because if you see, whenever you give an insulin to your patient, especially the intravenous insulin, where you will be giving for the diabetic ketoacidosis or hyperglycemic coma, so this can cause an acute shift of the potassium into the cells. So this becomes very, very important, because the diabetic ketoacidosis is a potassium depletion state. Already patient is having the potassium depletion. Because these patients are having acidosis, as I told you, acidosis shifts the potassium from intracellular to extracellular. If you give the insulin, and if you are correcting the acidosis by giving IV fluids, whatever the amount of potassium is there in the extracellular fluid is going to go back into the intracellular component, causing sudden drop in the potassium, which might precipitate the cardiac arrhythmias, which becomes sometimes serious in your patient. That's why you need to be very careful before giving insulin to any patient of diabetic ketoacidosis. The potassium should be normal is a rule. And similarly, you might have heard a disease called hypokalemic periodic paralysis, which is a channelopathy due to abnormalities in the calcium channel. Is an intermittent or a periodic type of paralysis occurring in a patient. So this transcellular shift mechanism also explains why a high carbohydrate load is a risk factor for these patients. Like if you take a lot of carbohydrates, there is going to be increased secretion of the endogenous insulin, which is going to cause sudden shift of the potassium into the intracellular component, which might precipitate the attack of an hypokalemic periodic paralysis. That's why the first and the foremost thing or advice we give for the patient of this hypokalemic periodic paralysis is not to take the heavy carbohydrates in their food. And suppose if the patient has hypokalemia with metabolic acidosis, you cannot give the bicarbonate directly in presence of hypokalemia, because if you give bicarbonate, as I told you, alkalosis is a thing which helps in moving the potassium from extracellular to intracellular compartment. If you give the bicarbonate to these patients, there might be a sudden drop in the potassium, which might again precipitate the cardiac arrhythmias. That's why if the patient has a coexisting hypokalemia with metabolic acidosis, you need to rise the potassium at least above 3 milliequivalents before giving sodium bicarbonate alone. Or it is always better to give potassium with bicarbonate. The potassium bicarbonate direct solution itself is available in these particular situations. And any adrenergic surge, like an acute myocardial infarction or a pancreatitis, the subarachnoid hemorrhage, the traumatic brain injury, the alcohol withdrawal, these kind of patients are going to have the sympathetic overactivity. So this can cause the hypokalemia in many of the patients. And patients who receive the large doses of the beta agonists, like if the patient is coming to you with an acute severe asthma where you are nebulizing the patients with the salbutamol or terbutaline, which are short acting, and so you will be using the beta agonists very frequently in the patients. And in case of the premature labor, you will be using the beta agonists like ritodrine, etc., especially in IV route. So these can also move the potassium into the cell, can cause sudden hypokalemia. And very rarely, if the patient is of vitamin B12 deficiency, if you supplement the vitamin B12 to these patients, there is going to be a sudden shift of the bone marrow to the hyperproliferative stage, so which might take off all the potassium which is there in the extracellular to the intracellular, can also cause the patients the hypokalemia. So this is a clinical importance of why the transcellular shift is very, very important in day-to-day life. And apart from the transcellular shift, in the transcellular shift, although the total body potassium is normal, either it is moving from or into the intracellular fluid, whereas the actual handling of the potassium excretion is being done by the kidney. Kidney is the major organ or the predominant organ which makes the regulation of this renal excretion of the potassium. So majority of the potassium which is filtered through the glomerulus is being reabsorbed maximally in the proximal convoluted tubule and next in the ascending loop of Henle. So if you see 90% of the potassium which has been filtered from the glomerulus is getting reabsorbed by the time it comes to the direct convoluted tubule. So, and the secretion of this potassium is going to take place in the terminal part of the DCT and the collecting duct, are also called as the CCD, that is cortical collecting ducts. The terminal part, that is D2 part of the distal convoluted tubule, and the cortical collecting ducts, where there are situated principal cells, are the very important cells which are involved in the potassium secretion. So body has got a balance to maintain the homeostasis. So if there is any drop in the potassium, the potassium reabsorption is increased. If there is hyperkalemia, the reabsorption is decreased. So these are going to happen to manage the homeostasis. So we should know how the principal cells act to secrete the potassium in the body. We know that the sodium is majorly absorbed in the distal convoluted tubule by the sodium chloride cotransporter and the ENaC channels, that is epithelial sodium channel, which are situated on the luminal side of the principal cells. So any amount of sodium which is being absorbed into the cell creates the net negativity in the lumen. We know that the electroneutrality is the rule in the body. So if the one positive ion is getting absorbed, the one positive ion has to be secreted from the distal tubule. So if the sodium is getting absorbed, it is the potassium which is going to be secreted by the very important receptor called the ROMK. This is a very important receptor. The 90% of the sodium secretion is going to occur through this receptor, whereas there is another receptor that is called as MAXCK or the BK receptor, where the some amount of potassium secretion is also going to occur. So more the negative charge in the lumen, more electronegativity in the lumen makes the potassium secretion more into the lumen. For example, if sodium is normal, whereas chloride is increased in the lumen, so net negativity is again going to increase, which makes the potassium to secrete. So any amount of the high chlorine in the urine is also going to cause the hypokalemia. This is the mechanism where the metabolic alkalosis causes the hypokalemia. So next, we need to remember how the mineralocorticoids are going to act on this ENaC. We know this ENaC is directly under the control of the mineralocorticoid receptor, and this is under the control of the aldosterone. So if the aldosterone activity is increased, the mineralocorticoid activity is going to increase, and which is going to act on the ENaC channel. So this ENaC channel is going to absorb more and more in sodium. So if the more sodium is getting absorbed, the potassium is secreted more, which will be lost in the urine. This is a major cause of the hypokalemia in these patients. So the hypokalemia to occur, or the renal wasting of the potassium to occur, there has to be two increased things. Either there is an increased mineralocorticoid activity, but the direct or the indirect route, if there is any amount of increased mineralocorticoid activity, this is going to cause hypokalemia directly. And if there is increased distal delivery of sodium and water, as I told you, if there is an increased distal delivery of sodium, for example, if you are giving the patient the loop diuretics, the loop diuretics are going to inhibit the sodium reabsorption in the loop of Henle. So more and more sodium is going to be delivered to the distal tubule. So this more and more sodium is being sensed by the distal tubule, is getting reabsorbed through the neck channel. So as I told you, more sodium getting reabsorbed in the distal tubule, the more potassium is going to secreted into the urine. That's why the diuretics are the major cause of hypokalemia. Again, the water. If there is more water secretion, if the increased flow in the urine is seen, like if any patient of polyuria, since the amount of time to reabsorb sodium is increased, so the amount of water is also increased. So these patients are going to have the hypokalemia patients. So normally the cortisol which is being secreted by the adrenal gland is although it has a potential mineralocorticoid activity, it usually does not act on the mineralocorticoid receptor situated in the collecting duct, because these cells possess a particular enzyme called 11 beta hydroxydehydrogenase enzyme. So this enzyme converts this cortisol to the cortisone, that is an active form, to the inactive form, to prevent the cortisol to act on the mineralocorticoid receptor. So if this enzyme is not functioning properly, cortisol is going to act on the mineralocorticoid receptor and tend to behave similarly how the mineralocorticoid activity increases with the hyperaldosteronism. So this 11 beta hydroxysteroid dehydrogenase to be deficient, there are two conditions. One, either it is lacking inherently, it is called as syndrome of apparent mineralocorticoid access, or if this enzyme is getting inhibited externally by some food items like the licorice or the drugs like the itraconazole or the posaconazole, all these are going to inhibit this particular enzyme. So these can stimulate the mineralocorticoid receptor and cause the hypokalemia. And if the action of this enzyme is overwhelmed, for example, if the secretion of cortisol amount is very high, so that it is not being handled by the enzyme in deactivating this can occur in case of Cushing syndrome, or if there is ACTH secreting tumor situated elsewhere in the body. So this can also cause the hypokalemia in your patients. So as I told you, the hypokalemia physiology, to understand the very important two basic mechanisms, it is important. One is the transcellular shift and another one is the renal excretion of the potassium. In renal excretion or the secretion, the major site is the cortical collecting duct and the second part of the distal convoluted tubule, where it is under the control of the aldosterone. Any amount of increase in aldosterone is going to cause the hypokalemia or increased excretion of this potassium, or any amount of increased delivery of this sodium to the distal tubule is going to cause the hypokalemia. So in keeping these basics, let's go to the etiology of the hypokalemia. So in your patient, the hypokalemia to occur, there has to be either of these three abnormalities. Either the patient is taking the potassium less through the oral route, or if there is an increased entry of this potassium into the cell, or called as intracellular shift or transcellular shift, or the potassium is getting lost from the body. It can be from the GIT, it can be from the kidney in the urine, it can be from the sweat. Although sweat, it is very rare. In the normal condition, it is not going to occur, the loss of potassium in the sweat. Only in uncommon conditions like an excessive exercise, marathon runners, or if the underlying channelopathies like the cystic fibrosis, etc., all these are going to or can have the hypokalemia due to increased sweat loss. So if you see this decreased potassium intake, so normally the potassium intake is the 40 to 120 milliequivalents per day in a normal person who is taking the normal diet. But our kidney has a ability to lower the potassium excretion in presence of lower intake. As I told you, body has got a tremendous amount of the homeostatic mechanisms. If you take the less amount of potassium in the diet, the body has got a compensatory mechanism to reduce the excretion in the urine. So the decreased potassium intake alone usually is never a cause of hypokalemia. Only in presence of the underlying conditions, it can precipitate the hypokalemia. For example, if the patient is on diuretic, if the patient is taking low potassium in diet, this might precipitate the overt hypokalemia in your patient. So the decreased potassium intake alone is rarely a cause of the significant hypokalemia. And increased entry into the cell, that is the transcellular shift, these are very, very important mechanisms. And the first and foremost thing is the increased availability of the insulin in the body. This can occur either with the exogenous administration of the insulin or the endogenous increased production of insulin. For example, the exogenous, it can occur when the patient is having uncontrolled sugars, or if the patient is presenting with the hyperglycemic emergencies, the diabetic ketoacidosis or the HHS, where we are giving the patients the IV insulin, this might precipitate the hypokalemia. The endogenous, for example, if the patient is taking the high carbohydrate load, this can also stimulate the insulin secretion from the endogenous pancreas. The very common instance is also when we give the dextrose containing fluids to the patient. So before giving any amount of dextrose to the patient, it is better to confirm the potassium beforehand, because if you are giving the dextrose to the patient, whatever the dextrose or the sugar which is been going into the intravenous route is going to secrete the insulin from the endogenous source, is again moving this potassium from the extracellular fluid to intracellular, can precipitate the hypokalemia. That's why whenever you correct this hypokalemia, the dextrose containing fluids are never used with the potassium. So it is always the normal saline which is being used to give the potassium chloride during the day-to-day management. And any amount of the elevated beta adrenergic activity, like the endogenous stress conditions, as I told you, the acute, the myocardial infarction, the pancreatitis, the hemorrhage, the brain injury, and alcohol withdrawal, etc. And exogenous beta agonist, as I told you, in case of the asthma, COPD, or if the premature labor, etc. So these situations can cause the hypokalemia. And elevated pH, that is alkalosis, either it is metabolic or respiratory, can move the potassium into the cells. And another very important thing is this alkalosis and hypokalemia are very close friends, and they usually coexist in a patient. Next is the hypokalemic periodic paralysis. As I told you, it is due to the channelopathies caused in the defect in the calcium channel, which is precipitated by exercise and the high carbohydrate meal due to transcellular shift. And a very rare instances, that is paradoxical hypokalemia after repletion. If you give the potassium supplementation to a patient of hypokalemia, sometimes there is a paradoxical hypokalemia which can occur in this patient. This is especially true for a patient of thyrotoxicosis and hypokalemic periodic paralysis. Although cause is unknown, the literature still defines this entity. And the increased red cell production or the white blood cells, especially the neutrophil, if you give the GM-CSF or if you give B12 and folate supplementation for the megaloblastic anemia, there is going to be the hyperplastic bone marrow, which is going to increase the red blood cell production, which are going to take up the potassium which is there in the extracellular fluid. If you look at the rare causes of this transcellular shift, the hypothermia. Although the hypothermia in case of the causing hypokalemia is usually either accidental or it can be induced hypokalemia. So sometimes hypokalemia is induced in a patient of hypothermia to prevent the brain death. The hypothermia patient can also have hyperkalemia due to the ischemic myopathies, etc. So the hypothermia is a one condition which can have the hypokalemia and hyperkalemia both. And the barium and cesium intoxications. So barium is used as either ingestion by the contaminated food or it can be suicidal consumption. What the barium and cesium does is they block the potassium movement from out of the cells. So these are the two items or the drugs which are not going to act by the sodium potassium ATPase. The mechanism of action is through the different mechanism, that is they block the potassium movement out of the cells through the different channel. The cesium is usually used as an antineoplastic agent, although rarely used nowadays. Then chloroquine intoxication. Chloroquine is a one drug you should remember in causing hypokalemia, which by inhibiting the potassium movement, which can causing the potassium from move into the cells. Sometimes if you are giving the patient the chloroquine, the potassium may go as below as 2 milliequivalent, so it can be significant sometimes. And the atypical antipsychotic drugs like the risperidone and quetiapine can cause the hypokalemia, although exact mechanism is not known for these two conditions. So if you see the drugs which can cause hypokalemia here, it is the insulin, the first comes into the condition, and any the beta-2 agonists, and the vitamin B12 and folate, and the chloroquine, which is an anti-malarial drug, and the atypical antipsychotic drugs, that is risperidone and quetiapine. So if you know this basic chart, you can answer the question relating to this particular condition in the exams. So next, and the most common cause of the hypokalemia by reducing the total body potassium is the loss of this potassium from the body fluids. So it can be from the GI tract or from the kidney, or very rarely from the sweat. So from the GI tract, yes, the lower GI loss. We know that potassium is very high in case of the lower GI secretions due to the situation of this colonic BK channels, which actively secrete this potassium. So any amount of increase in the diarrhea, either it is a persistent infective diarrhea, or it is a villous adenoma or VIPoma, and the patient of laxative abuse, all these can lose the potassium over a prolonged period of time, can also cause the hypokalemia. And this hypokalemia is usually associated with hyperchloremic non-anion gap metabolic acidosis. I think we discussed in this particular thing in the class of metabolic acidosis. And the upper GI loss, very rarely it can cause hypokalemia, although the potassium concentration in case of the gastric secretion is very low, yet the patients of severe vomiting are going to have the hypokalemia. So this has to be understood. Why this hypokalemia occur in case of upper GI loss or severe vomiting? This is because the hypokalemia is basically due to increased urinary loss in the patient. So in case of vomiting, the urine is not getting lost from the GI tract, it is getting lost from the kidney. This is because we know that any amount of significant vomiting is going to cause the increased bicarbonate in the patient, that is metabolic alkalosis. So this increased bicarbonate is being handled by the kidney by excreting more and more amount of bicarbonate into the urine. So this increased amount of bicarbonate, as it is a negative ion, is going to increase the net negative charge of the lumen in the collecting duct, is going to cause the potassium movement out from the principal cells to the urine, causing the hypokalemia. So this is a very, very important mechanism. The cause of the hypokalemia in case of the severe vomiting is bicarbonate urea. This can also be the question. This, I think it has been already asked in the AIMS exam. So why the hypokalemia occurs in case of upper GI loss or severe vomiting is a very, very important mechanism. Even if you measure the urinary potassium in case of the upper GI loss or severe vomiting, it is going to be very high. So it's a natural tendency to think that potassium is getting lost from the GI tract in the severe vomiting. It is not the case. In case of severe vomiting, the potassium is actually losing through the kidney. Whereas in the lower GI loss, it is straightforward. It is straightforward that the potassium is being directly secreted by the colonic cells, which is going to lost in the stool. There are some rare conditions in causing hypokalemia, that is the bowel preparations for the surgery or for the labor conditions and for some procedures with either sodium phosphate or the PEG based preparations can cause hypokalemia. And acute colonic pseudo obstruction, also called as Ogilvie syndrome, can also be the cause of this hypokalemia. And sometimes the ingestion of clay, that is geophagia, where the substances in the mud are going to bind to the potassium which is there in the food, which is inhibiting the potassium absorption. So these are some rare causes. So apart from the GI tract, the very clinically important causes of this hypokalemia are the increased urinary loss of the potassium. So if you see the causes of this increased urinary loss of the potassium, there are major causes. There are 4 major causes that should directly come into your mind. That is, first and foremost thing is the diuretic use, then the increased mineralocorticoid activity, and the non-reabsorbable ions, and the loss of gastric secretions. As I told you in the previous slide, the loss of gastric secretions are going to cause the bicarbonate urea in your patient, which are going to cause the hypokalemia by increasing the secretion. So there are four major causes of this urinary potassium wasting. The first is diuretic use, and second is mineralocorticoid activity. These are the very two most common things. Then there are non-reabsorbable anions and the loss of this gastric secretions. If you look at the minor causes or less common causes, the polyuria, as I told you, any amount of the increase in the distal tubule flow is going to cause hypokalemia. Then the renal tubular acidosis, then the hypomagnesemia, the drugs like the amphotericin B and salt wasting nephropathies, the Liddle syndromes, the Bartter and Gitelman syndrome, and low calorie diets. So if you look at these one by one, the diuretic use, all types of diuretics, we know the types of diuretics. One is the loop diuretics and the thiazide diuretics, then the mineralocorticoid receptor antagonists. So any diuretic which is going to act proximal to the potassium secreting site, that is the distal tubule or the second part of distal tubule, any diuretic which is acting proximal to this site. So what are the diuretics which acts proximal to this site? The loop diuretics, yes, they act in the loop of Henle, and the thiazide diuretics, yes, they act in the first part of the distal convoluted tubule, and the acetazolamide, which is also not typically used diuretic but can be considered as a diuretic which is acting on the proximal tubule. So all these diuretics are going to cause the hypokalemia. How we know this is because they inhibit the sodium reabsorption in the proximal part, increasing the distal delivery of the sodium to the distal tubule or the potassium secreting site, where this whatever the extra amounts of sodium is going to compensate by the increasing reabsorption of the sodium by the ENaC channel by increasing the reciprocal potassium excretion. And if you see this hypokalemic effect of the diuretics, it is a dose dependent action. For example, more the dose you're using, the more is the risk of hypokalemia. That's why if you see the thiazide diuretics, nowadays the antihypertensive dose used for the chlorthalidone and hydrochlorothiazide is very low dose. Like if we are using 6.25 mg, 12.5 mg, maximum 25 mg of these both drugs, which are usually not associated with the hypokalemia. The increase in dose is going to cause the hypokalemia in your patient. So antihypertensive dose of this diuretics rarely causes hypokalemia in day-to-day life. So if you compare this, the thiazide diuretics and loop diuretics, the thiazide diuretics can cause hypokalemia much more commonly than loop diuretics. Even though thiazide diuretics has less natriuretic effect, their caliuretic effect is much more common than loop diuretics because this is due to differential calcium excretion. We know that loop diuretics causes the increased calcium excretion in the urine, whereas thiazide diuretics causes the decreased calcium excretion in the urine. That's why these drugs are used for the nephrocalcinosis or the patient of recurrent urinary calcium stones to reduce the calcium secretion. So this thiazide diuretics, as they secrete less amount of calcium into the urine, the net negative charge of the luminal fluid in the collecting duct is going to be more negative. That's why the potassium is going to be secreted is more in case of thiazide diuretics compared to the loop diuretics. So the differential calcium excretion is the reason for the more caliuretic effect of the thiazide diuretics. So if somebody asks you which is more potent diuretic, yes, definitely it is a loop diuretic. And if somebody asks you which is more potent in causing hypokalemia, the answer is the thiazide diuretics. Next, as I told you, any amount of increase in the mineralocorticoid activity by directly stimulating the ENaC channel is going to cause the potassium wasting. Among that, it can be either primary hyperaldosteronism or secondary hyperaldosteronism. The primary hyperaldosteronism, this is a separate discussion in the endocrinology. It is either familial or it is isolated, whereas the most common cause of this primary hyperaldosteronism is usually the Conn syndrome, that is an adenoma secreting the mineralocorticoids. or it can be secondary hyperaldosteronism. Like there is some other cause which is secreting the renin in the body, like it is either the renal artery stenosis, it is a chronic diuretic use, or it is hypertension or hypovolemia of any cause, which are going to act by increasing the RAS system. So the most common cause of this secondary hyperaldosteronism is the renal artery stenosis, is also a cause of this hypokalemia. Next, apparent mineralocorticoid excess. As I told you, the cortisol usually or normally does not act on the mineralocorticoid receptor because of the enzyme called 11 beta hydroxysteroid dehydrogenase. If the enzyme is deficient, the cortisol is not getting converted or not being inactivated, is going to act through the mineralocorticoid receptor, behaving like the hyperaldosteronism. That's why this condition is also called as pseudo hyperaldosteronism. Then Cushing syndrome. In Cushing syndrome, there is overwhelming secretion of this cortisol, even though the 11 beta hydroxysteroid dehydrogenase enzyme is present. It is the overwhelming secretion of this cortisol is going to act through the mineralocorticoid receptor, causing this. The CAH, that is congenital adrenal hyperplasia, either the deficiency of the 11 beta hydroxylase or the 17 alpha hydroxylase. These two deficiencies are going to cause the hypertension and hypokalemia in the patient of congenital adrenal hyperplasia, whereas 21 hydroxylase deficiency is not going to cause hypertension. Then non-reabsorbable ions. When sodium, which is being filtrated in the glomerulus, is presented to the distal tubule combined with the large quantities of non-absorbable anions. So sodium, since it is a positive ion, usually have a tendency to combine with the negative ion. So if there is increase in the amount of negative ions in the body, like if the patient has more amount of bicarbonate in the blood, so the more and more sodium is going to bound to the bicarbonate. So this bicarbonate is being delivered to the distal tubule, as I told you, the same reason in vomiting, and similarly in case of the proximal RTA, as there is impaired secretion of the bicarbonate, impaired reabsorption of the bicarbonate. So this can cause the hypokalemia in your patient. In case of DKA, we know that these ketones, predominantly the beta hydroxybutyrate, is a negative ion, is going to combine with the sodium, and this can cause hypokalemia with the same mechanism. And hippurate in the glue sniffing addiction, hippurate is a negative ion formed in the mechanism of the toluene gas metabolism in the body. Then penicillin derivatives, as the penicillin derivatives are the negative ions which usually excreted by the actual combination with the sodium. So this penicillin derivatives, especially if we are using in a high dose in a prolonged time, can also cause the hypokalemia in your patient. And as I told you, the loss of gastric secretions is also going to cause the hypokalemia by the same mechanism. And all these mechanisms are going to worsen in the presence of the volume depletion because of secondary hyperaldosteronism. And if you see the less common causes, the polyuria, especially if the urine output is very heavy, like 5 to 10 liter, the amount of sodium which is time to absorb this potassium which is going to flow in the urine is reduced. So the potassium is being lost obligatorily in the urine. So this is very common in case of primary polydipsia. Sometimes the central diabetes insipidus can also cause the hypokalemia due to increased flow. And the renal tubular acidosis, this potassium wasting occurs both in type 1 and type 2 RTA. Only type 4 RTA is associated with the hyperkalemia, whereas all other types of the renal tubular acidosis are associated with hypokalemia. This very important condition in case of renal tubular acidosis is, as I told you, acidosis shifts the potassium from intracellular to extracellular. Whenever there is an acidosis, there is masked hypokalemia in a patient due to extracellular movement of this potassium. So if you correct this acidosis in a patient, so whatever the amount which is being secreted into the extracellular fluid is again tends to go back to the intracellular compartment by uncovering the hypokalemia or the uncovering the true state of potassium balance in your patient. So be very careful when correcting the acidosis, especially the long-standing acidosis in your patient, which can manifest the sudden hypokalemia causing arrhythmia if you are not looking into the potassium directly. Then hypomagnesemia by tendency of two mechanisms. One is the causes of this hypomagnesemia and hypokalemia are usually coexisting. Like if the patient is on diuretic therapy, if the patient is having severe vomiting, if the patient is having diarrhea, and if the patient is taking some tubular toxins where the magnesium is getting absorbed, like gentamicin and ifosfamide, these are going to inhibit both the potassium and the magnesium reabsorption. And hypomagnesemia by itself directly can cause hypokalemia, although the mechanism is unknown. So hypomagnesemia is a condition which can cause both hypokalemia and hypocalcemia in your patient. I think the calcium and hypomagnesemia we discussed in the last class. Then a very important thing in hypomagnesemia is the hypokalemia is often cannot be corrected till the magnesium deficit is reversed in a patient. This is similar in case of hypocalcemia. Always correct magnesium before correcting the potassium and calcium in your patient. Then amphotericin B is a notorious, is a direct tubular toxin, can cause the hypokalemia in your patient. This actually interacts with the membrane sterols, leading to increased membrane permeability, causing the secretion of the potassium into the urine. So this can also be associated with the concurrent distal RTA. So this amphotericin B is very common in causing the acute kidney injury by direct tubular toxicity, that is acute tubular necrosis, and it can cause the hypokalemia, and it can cause the non-anion gap metabolic acidosis. So whenever a patient of amphotericin B, usually after starting some 2 to 3 days, if at all you are using the, if you're not using the liposomal variety, it is very important to look for these side effects in your patient. The hypokalemia is being very difficult to manage in case of amphotericin B. If any PG has managed this, might know the difficulty of managing hypokalemia in amphotericin B. Then salt wasting nephropathies I have not dealt separately, because salt wasting nephropathies directly like Fanconi, etc., they are not absorbing the potassium in the proximal tubular, going to loss in the urine. If you see the Liddle syndrome is actually a gain of function of mutation in the ENaC. As I told you, ENaC is a channel which reabsorbs the sodium. If the activity of this channel is increased, there is more and more sodium is getting absorbed. So this actually mimics hyperaldosteronism, but actually the aldosterone is normal here. So, but since the channel defect is there is activating mutation of this channel, they are going to behave similarly to the hyperaldosteronism. That's why this condition is also called as pseudo hyperaldosteronism. So this is a combination of the hypokalemia, hypertension, metabolic alkalosis. This is also called as combination of the hyperaldosteronism, but with the normal renin aldosterone ratio in this patient. That's why this condition is called the pseudo hyperaldosteronism, and this is a condition which is autosomal dominant. Whereas if you see other channelopathies like Bartter's and Gitelman's, they are autosomal recessive. Next, the Bartter and Gitelman's. We know that the Bartter, there is a defect in the loop of Henle, and Gitelman's, it is in the distal convoluted tubule. So there is hypokalemia in both the conditions, there is alkalosis in both the conditions, and there is hypotension in both the condition because of loss of sodium in the urine also. So till this point of time, they are similar. That is, in causing the hypokalemic metabolic alkalosis, the Bartter and Gitelman are similar. How to differentiate between Bartter and Gitelman's? As I told you, their mechanism of action is in the loop of Henle. They behave like loop diuretics. So since the loop diuretics causes hypercalciuria and the thiazide diuretics causes hypocalciuria, this is by the differential excretion of their calcium, you are going to differentiate between Bartter and Gitelman's. So this Gitelman's behaves like a thiazide toxicity, and the Bartter's behaves like a loop diuretics of toxicity, and both are autosomal recessive, both are having hypokalemia, both are having volume deficient state, both are having hypertension, both are having metabolic alkalosis. The only thing which differentiates is the urinary calcium excretion. it is hypercalciuria in case of the Barters, whereas the hypocalciuria in case of Gitelman's. There is another entity which might be tested in the exams, that is the differential magnesium excretion. That is, the Gitelman is a condition which is associated with the hypermagnesiuria, that is increased magnesium excretion. That's why this condition is associated with hypomagnesemia. So whenever the question is asking the differential diagnosis between the Bartter and Gitelman, there are two things you can look for. One is the urinary calcium excretion, and the other thing is the magnesium concentration in the serum, that is hypomagnesemia. So these are the two things which differentiates between the Barters and Gitelman's. And it is very important to remember that Barters behaves like a loop diuretic toxicity and Gitelman behaves like a thiazide toxicity. And you can form your own mnemonic to remember this. What I remember is, since Bartter is a small word and loop is also a small word, Bartter goes with the loop, whereas Gitelman is a little bit longer word, and similarly the thiazides. So this goes with the Gitelman's. So what are the manifestations of hypokalemia in your patient? So this is definitely directly proportional to the degree of hypokalemia. Like if the patient is having mild hypokalemia, that is between 3 to 3.5, may not have any symptoms. Symptoms usually appear in case of moderate or severe. The moderate is called 2.5 to 3, and anything which is less than 2.5 is severe hypokalemia. So mild hypokalemia may not have any symptoms, whereas the moderate hypokalemia may have symptoms. So some patients may have symptoms even with mild hypokalemia if they have any predisposing conditions, if they have the pre-existing coronary artery disease or any organic heart disease for that matter, or if the patient is on digoxin or the digitalis, or if the patient is having or receiving anti-arrhythmic drugs. So in these three conditions, your mild hypokalemia can also become very significant. In fact, they worsen symptoms. So what symptoms they usually cause? They can cause the muscle weakness and they can cause the cardiac arrhythmias, the two very important life-threatening abnormalities. The kidney abnormalities are common but rarely significant. The glucose intolerance is very, very important. The hypokalemia, as I told you, the insulin secretion from the islets of the pancreas for beta cell is very, very important and depends on the potassium concentration. If there is less potassium, the amount of insulin secreted is also less. This is actually the body's defense mechanism. As the hypokalemia is worsening, the body is reducing the insulin secretion to inhibit the movement of this transcellular shift. So this is the body's mechanism. So this can become troublesome if there is a long-standing hypokalemia. So the similar hypothesis is being given for the diuretic-induced hyperglycemia in your patient. Initially, there was a hypothesis that chronic diuretic therapy, especially the thiazide diuretic therapy, is going to convert the patient from pre-diabetes to over-diabetes. So this was actually mediated through the hypokalemia by reducing the insulin secretion in your patient. So although this is still a believed entity, hypokalemia can cause glucose intolerance in your patient if they are non-diabetics, or if they can convert the pre-diabetic patients to over-diabetic, especially if this hypokalemia is long-standing. So this is very, very important to remember. And if you see the muscle weakness, as I told you, directly depends on the potassium concentration. The more the drop in the potassium, there is more the muscle weakness is going to occur. So this can occur when the hypokalemia is usually below 2.5, that is a very severe hypokalemia. It can be occur when it is sudden in onset. Like even if there is a drop is low, if the drop is sudden, it can occur in practice. So this is a lower motor neuron type of weakness, that usually ascending type, begins in the lower extremities, then progresses to the trunk and upper extremities. Sometimes this can involve the respiratory muscles it can become severe enough to need the mechanical ventilation in your patient. And the involvement of the smooth muscles in the GI tract can also result in the paralytic ileus. So this is also very, very important in the post-surgical wards, where the potassium is being routinely monitored in case of the subacute intestinal obstruction, etc. And the severe potassium depletion can also cause the muscle cramps and the rhabdomyolysis. Why this rhabdomyolysis occur? In case of hypokalemia, the mechanism you should understand, because body has a normal mechanism that during exercise the body needs more blood, or the muscle needs more blood. So this more blood is going to be delivered with the vasodilatation which occurs during the exercise. So this exercise induced vasodilatation is mediated by the potassium ions. So whenever there is hypokalemia, there is no exercise induced vasodilatation. So if you exercise, whatever the amount of blood that is being needed extra is not going to deliver, so which can cause the rhabdomyolysis, that is ischemic rhabdomyolysis in your patient. So this severe potassium depletion causing rhabdomyolysis usually occurs when patient does exercise in presence of the hypokalemia. So this rhabdomyolysis, we know it is the breaking of the muscle protein. So, and there is a breaking of cell. The potassium is directly getting secreted into the blood from the muscle cell or the myocyte. So during or once the rhabdomyolysis sets in, your patients, if you check the serum potassium, it is usually showing hyperkalemia. So it is very difficult to differentiate the hypokalemia induced rhabdomyolysis once the rhabdomyolysis sets in. If you check the potassium, it may come actually in a higher level. So the muscle weakness, it is very, very important to remember that it is usually a severe feature, can occur if it is sudden drop. It can become severe enough to involve the respiratory muscles, and it can involve both skeletal muscle and small muscles, and sometimes it can cause the exercise induced ischemic rhabdomyolysis in your patient, which can cause myoglobinuria and the acute tubular necrosis due to direct toxicity. And the next and the most important side effect of this hypokalemia is the cardiac dysrhythmias or arrhythmias. So hypokalemia is actually associated with the variety of arrhythmias. This is usually associated with both the tachyarrhythmias very commonly, and also associated with the bradyarrhythmias. So this tachyarrhythmias, can be associated with atrial tachyarrhythmias. It can be associated with junctional tachyarrhythmias. It can be associated with ventricular tachyarrhythmias. It can be associated with any type of arrhythmia if you take that name. So majority, if it is mild, it can usually cause the premature atrial complexes or the premature ventricular complexes. It can also cause the junctional bradycardia. It can also cause the junctional tachycardia. It can cause AV block, and very severely it can cause the ventricular tachycardia and the ventricular fibrillation. Why this occurs? It occurs usually because of the delayed ventricular repolarization. We know that the repolarization is mainly dependent on the potassium movement. So since the potassium is not been available, so this delays the ventricular repolarization. So this hypokalemia, usually to produce a characteristic ECG changes, which we are going to discuss in the next slide, is usually occurs below the 2.7. So this can be the entrance question. In fact, this was an entrance question, and this value is directly mentioned in the Harrison textbook also. So hypokalemia, to produce a characteristic ECG changes, what is the potassium level should be? So it should be below 2.7 milliequivalents. And as I told you, the presence of the concomitant risk factors like the coronary ischemias or any amount of organic heart disease, the digitalis, or increased beta adrenergic activity, the magnesium deficiency, which is coexisting with the hypokalemia, can promote the development of these arrhythmias. So if you look at the ECG tracing normally, so we know there is a P wave which depicts the atrial depolarization. There is a QRS which depicts the ventricular depolarization, and there is QT segment and T wave which depicts the ventricular repolarization. So this is the basic of ECG. So as I told you, there is an abnormality in the ventricular repolarization. Where do you think the abnormality is going to manifest in the ECG? So the ventricular repolarization, it is the ST segment and the T wave, the site where the potassium abnormalities are usually manifest. So if you look at the exact changes which usually occurs in case of hypokalemia, the first and foremost thing to occur is the abnormality in the T wave. That is the progressive diminution in the amplitude is the first sign to appear in case of hypokalemia. As I told you, that it is the delayed repolarization. So T wave gets prolonged, diminished in the amplitude. Sometimes it may disappear or become inverted in your patient. Sometimes the T wave may remain as a remnant by a slight irregularity in your patient. So there is an appearance of U wave. So this U wave may become progressively increase in amplitude and maintain its rounded appearance. Like there are irregular U waves and there are regular U waves. If you see the ECG, you will understand this. So this hypokalemia is a cause of the regular and rounded U waves in your patient. So the T waves are going to disappear and U wave is going to appear. Sometimes you may confuse U wave for the T wave in your patient if the T wave is absent and the U wave is rounded in your patient. Sometimes they get superimposed to form the TU complex in your patient. If you see the ST segment, the ST segment is in all leads usually depressed horizontally or concave upwards. This is what is concave upwards. In case of MI related, it is usually convex upwards, but in hypokalemia, it is the concave upwards. And the prominent U wave combined with ST segment depression and flattened T waves is called as the roller coaster effect. So if you see this ECG, after this end of the S wave, the ST depression may come and then the TU wave come. So this is called a roller coaster effect, which is seen in the hypokalemia. This can be the entrance question also. The roller coaster effect is seen in which electrolyte abnormality. Then if you see the QT interval, actually QT interval may be unchanged. But sometimes there is a tendency to confuse U wave for the T wave or the TU complex. So there is a mistaken U wave consideration may lead to the incorrect diagnosis of the QT prolongation in your patient. That instead of the diagnosing hypokalemia, you may consider the patient as having hypocalcemia. So this is a wrong thing. So this hypocalcemia, even though it prolongs QT, does not reduce the T wave amplitude and does not cause ST depression. Whereas if there is an ST depression, you need to suspect the hypokalemia in your patient. Then P waves, although abnormalities of P wave are also seen in case of severe hypokalemia, the very important thing which is being mentioned in the literature is the increase in the P wave amplitude. It is also called as pseudo P pulmonale. We know that P pulmonale, which is occurs in case of COPD or any chronic respiratory diseases, increase in the P wave amplitude more than 2.5 small squares. So sometimes, if you see the ECG, there is P pulmonale, but if you get to evaluate for the patient, no other cause of the respiratory system is found out, then it is called as pseudo P pulmonale. It's a very common manifestation in case of hypokalemia. This question was asked in my PG entrance in 2015. The pseudo P pulmonale is seen in. So this is a feature of the hypokalemia. And sometimes the AV blocks are common, both the first degree and second degree Vancouver due to sequential prolongation of the PR interval can also occur in case of the hypokalemia. So there is a lot of varieties in hypokalemia. So if you see, the majority of these are due to repolarization delay. So they appear in a T wave and ST segment. There is progressive diminution of the T wave and appearance of the U wave, and the ST depression may ensue. And this U wave may be confused for the T wave by overestimating the QT interval in your patient. So if you see this particular ECG, see this rhythm strip here in the lead 2, there is ST depression and there is a U wave. This is a feature of severe hypokalemia. So this is also called as this roller coaster effect. This is a very beautiful ECG tracing, which I took from the Life in the Fast Lane. the very important thing. So if you see the tracing magnification here, there is actually the T wave inversion along with the ST depression and the appearance of the U wave. So if you consider this as a T wave, there is actually the prolongation of the, it appears like QT is prolonged, but actually T is here. The QT interval may be normal. This is being depicted in the same here. So this is also very important ECG. If you see the earlier part here, there is an ST depression, there is a T wave inversion, and then the appearance of U wave. So this is a very beautiful tracing also. There is a T wave inversion along with the appearance of U wave. So, and while taking the tracing, there is a sudden atrial ectopy arising in this patient, which has been falling exactly on the T wave of the previous QRS. If you take extra actual modification here, so this is a P wave, this is a QRS, so this is a T, exactly with the T, the ectopy is falling, then it is going to cause, or it is causing the polymorphic VT. So this is called as R on T phenomenon. R on T phenomenon is a very notorious phenomenon in causing the ventricular arrhythmias. So if you know how to read the Holters, it becomes very useful in monitoring the Holters. This is a very common entity we usually see in case of the long QT syndrome of any cause, hypocalcemia or congenital long QT syndromes or any drug-induced long QT, this hypokalemia-induced ventricular arrhythmias, usually having a prolonged QT or a QU. So this, whatever the ectopy which has been coming, which directly falls on the T wave, which can manifest as a burst of ventricular arrhythmias. So this polymorphic VT is also called as torcidus B pointus. The polymorphic VT occurring in the background of QT prolongation is called as torcidus B pointus. Any polymorphic VT which is occurring in the background of QT prolongation is called as torcidus B pointus. Can also occur due to hypokalemia. It can also occur due to hypocalcemia, although it is very rare. So if it is polymorphic VT, if it occurs in the background of normal QT interval, then it is called just polymorphic VT. If it is occurring in the background of the prolonged QT, then it is called as torcidus B pointus. So if you see this particular ECG, here, if you look at the first time, it may seem as a dominant ST elevation in case of V2, V3, V4, and V5 and V6 also. This may be an anterolateral MI. This looks like an anterolateral MI. If you look at the 2, 3 AVF also, there is an ST elevation. So the grossly, if you look, or if the untrained or a trainee looks this ECG, he may tends to confuse this particular ECG as the MI and may trigger the coronary call. And sometimes patient may end up in going for the coronary artery angiogram. But this is also a manifestation of the hypokalemia in the patient. This particular tracing I took from the blog of Dr. Venkatesan, who is a renowned cardiologist. So this is the same patient after getting the correction of the hypokalemia. In this patient, the potassium was actually 1.3. So there is a lot of heterogeneity in the presentation of this hypokalemia in the day-to-day practice. So in any patient who is coming with any amount of cardiac rhythm abnormality, the potassium measurement is a must. Please remember this. Potassium measurement is must and first. This is a very important rule in the cardiology of any rhythm abnormalities, and even though with the STT abnormalities. So always have a mind of the hypokalemia and hyperkalemia before taking the patient for any intervention. So if you see this ECG, so if you look carefully, it appears like an atrial flutter. This is a lead-2 rhythm strip. So this appears like a 3 P waves with a 1 QRS. So this can also appear like a 3:1 atrial flutter. Whereas in fact, this is a T wave, this is a U wave, this is a P wave. This is a T wave, this is a U wave, this is a P wave. So this is also one of heterogeneity in case of the hypokalemia. So this hypokalemia with the appearance of U wave can also mimic the atrial flutter. So this is another example to train the young doctors to look for the potassium abnormalities before concluding any rhythm disturbances in a patient, in patients of organic heart disease. Before labeling your patient of any organic heart disease, always rule out the potassium abnormalities. So next, coming to the hypokalemia-induced kidney dysfunction. The prolonged hypokalemia can cause the impaired urinary concentrating abilities by directly inhibiting the channels, that is aquaporin 2. That's why these hypokalemia long-standing can also cause the nephrogenic diabetes insipidus. It can cause intracellular acidosis. As I told you, since the potassium is being secreted with the sodium being reabsorbed excessively, sometimes along with the sodium there is another positive ion may come, H plus, into the cell, so which can cause the intracellular acidosis in this patient. So this intracellular acidosis, to balance the acid base status, along with this can take the ammonium ion along with it in the principal cells. So this can also cause increased ammonia production in the patient of hypokalemia. This is a very, very important pathology in how the hypokalemia precipitates the hepatic encephalopathy in your patient. So this is a mechanism how the hypokalemia can precipitate hepatic encephalopathy in a patient of the uncomplicated chronic liver disease. If you read the precipitating factors for the what you call the hepatic encephalopathy, hypokalemia or the electrolyte disturbances becomes the first. Hypokalemia is very common because invariably the patient is on diuretics. And if the hypokalemia is there, this in a long-standing case can cause the increased ammonia production, so can precipitate the hepatic encephalopathy. Along with this, this can also cause the increased bicarbonate reabsorption, altered sodium absorption as an acute thing. And there is a particular entity called hypokalemic nephropathy, where the long-standing hypokalemia can cause the tubular functional defects and sometimes causing tubular atrophy. So the chronic tubulopathy can occur, manifesting as the CKD in a long-standing hypokalemia in your patient. So this kidney abnormalities usually tend to occur only if the persistent hypokalemia is there, and majority of them are reversible with the repletion. Then if you evaluate the patient with hypokalemia, this is a basic flow chart which is being given in the Harrison. It's a very important thing to revise before going into any exam or even during the management of patients. So this has to be applied in the wards, medicine wards, the practicing site. So in evaluating the history, the physical examination and the laboratory evaluation are very, very important. By the time history and laboratory physical examination is done, some of the causes are actually ruled out. So rule out the medications, majority the diuretics, the laxatives, and the antibiotics, especially the penicillin group of drugs, or if the patient is on any non-specific, the antifungal therapies like the Amphotericin B, the itraconazole, the posaconazole, etc. And check for the diet and dietary habits, that is the licorice. Licorice is a very, very important thing, which is actually consumed as a powder. Licorice root is consumed as a powder in many of the partisan the Ayurvedic practice. So this licorice contains one compound called glycyrrhinic acid. So this licorice, in Hindi it is called as mulethi, and in Kannada and Sanskrit it is called as Jyeshtha Madhu. So people tend to consume this for peptic ulcer disease, for some immune booster, etc. So this licorice is directly going to inhibit the enzyme called 11-beta hydroxysteroid dehydrogenase, which usually converts the cortisol to the cortisone. So inhibition of this can increase the concentration of cortisol, causing the mineralocorticoid activity. And look for the symptoms of specific diseases like the diarrhea, periodic weakness, vomiting, etc. Then the state becomes directly in the physical examination, you need to check the very important two things, that is the volume status and the blood pressure. If the blood pressure is normal, then the 2 or 3 conditions are definitely ruled out. That is, the hyperaldosteronism is ruled out, and if the syndrome of apparent mineralocorticoid excess is ruled out, the Cushing's is ruled out, and the Liddle's is ruled out. So this becomes very, very important to assess the blood pressure and the volume status. Then comes the laboratory evaluation. The routine blood tests and the urine tests are very, very important. And the urinary potassium excretion is very, very important to know where the potassium is losing, whether it is in the urine or it is in the extrarenal site. Then the acid-base status. So if you know the blood pressure plus the acid-base status, 90% of the diagnosis is being done. Only some difficult disorders it is requires the urinary potassium excretion in your patient. So let's go ahead with this potassium excretion measurement. To know whether the potassium is getting wasted from the kidney or from other side, you need to measure the amount of potassium that is being excreted in the urine. So this can be done by the 24-hour urine potassium measurement, like ask the patient to collect the urine for 24 hours, then measure the potassium in it. So this is actually the best method to actually measure how much potassium is losing. The excretion of the 30 milliequivalent potassium per day or more in presence of the hypokalemia indicates the inappropriate renal loss. So you are seeing a patient of hypokalemia, and if you measured the 24-hour urinary potassium in this patient, if it is more than 30, then think that kidney is losing the potassium. And sometimes this particular test becomes impractical because potassium depletion is urgently needed. For example, if you see a patient who is presenting with a cardiac arrhythmia, potassium is 2.5, you cannot just wait for the 24-hourly urine collection and then correcting the potassium, because if you correct the potassium, the value may become abnormal. So that's why the spot urinary potassium tests have become very, very common nowadays. So to avoid this cumbersome procedure, we usually measure this urinary potassium creatinine ratio. So to compensate for the 24-hour urine, because the creatinine is excreted at a near constant rate, the urine KCR corrects for the variations of the urine volume. This is similar in all other conditions. Like instead of measuring 24-hour urine protein in case of the nephrotic syndrome, we usually go for albumin creatinine ratio or protein creatinine ratio. Similarly for calcium, similarly for sodium, anything, if you correct the excretion, spot urine excretion to the creatinine, you can directly compensate for the 24-hour urine. So in any patient, if the urine potassium creatinine ratio is less than 30 milliequivalent per gram of creatinine, it is suggestive of extrarenal loss. And if it is more than 30 milliequivalent per gram of creatinine, then the kidney is losing the potassium in your patient. So you need to remember this number. This is being given in the Harrison also. Whereas this 30 has been a controversial, the American Society of Nephrology and Up to Date both mention 30, about 30 as the renal wasting potassium, whereas Harrison mentions 15. Some textbooks also mention the 15 millimoles per day. So you can either say 15 according to the Harrison or 30 according to the American Society of Nephrology, whatever the way it is convenient to you. And there is another thing you can measure to avoid the 24-hour urine potassium measurement is the transtubular potassium gradient. This is actually the ratio of the potassium you measure in the lumen of the CCD versus the peritubular capillaries. So if you see this is the lumen, and if there is a collecting duct and the peritubular capillaries, you are basically measuring the gradient, the amount of potassium in the lumen and amount of potassium in the blood or peritubular capillaries. That is the transtubular potassium gradient. So this is the formula where the potassium is corrected for the urine osmolarity. So in normal patients who are on normal diet, the normal TTKG is 8 to 9. So in case of extrarenal loss, it should be less than 2. So in a patient of hypokalemia, if you measure this transtubular potassium gradient, if it is more than 4, then it is suggestive of the renal potassium wasting. So if you see, to diagnose the renal potassium wasting, you need to have either the 24-hour urine potassium of more than 30 milliequivalent, or you need to have the potassium creatinine ratio of more than 13 milliequivalent per gram of creatinine, or the transtubular potassium gradient of more than 4. Any of these three conditions can tell you that your potassium is getting wasted from the kidney. But this is not as simple as we say, because it needs proper biochemistry professors to measure this. I still remember where I was dealing case of the hypokalemia and reevaluation in my PG time, where I had told my junior PG to give a sample of the spot urine to the biochemistry lab and go directly speak with the professor to measure this potassium creatinine ratio. The consultant actually took 3 days to measure the actual potassium creatinine ratio because of busy schedule. So this is a very cumbersome procedure. Many of the laboratories usually does not measure. You need to specially request for these kind of tests to occur in your practice. So after measuring this TTKG and after confirming that it is the potassium wasting which has been occurring in the kidney, then you need to assess the blood pressure. If the blood pressure is high, then their diagnosis is different. Then the blood pressure is different, or the normal or the low, then the differential diagnosis is different. Another differential diagnosis which usually I happen to follow is, after measuring the blood pressure, just check the acid base status, because there are conditions which are associated with hypokalemia and metabolic acidosis, and hypokalemia and metabolic alkalosis. So if you see here, after confirming the renal potassium wasting, this particular flow has been mentioned in the Journal of American Society of Nephrology. So this is a very simple one to practice. After measuring that, just measure the acid base status. If there is metabolic acidosis, the majority of the causes have been ruled out. The hyperaldosteronism is ruled out, the diuretic toxicity is ruled out, the Gitelman Barters are ruled out, the vomiting is ruled out, everything is ruled out in the absence of metabolic alkalosis. If the metabolic acidosis you see, then it is either diarrhea or the toluene toxicity, as well as glue sniffing, or it is type 1 and type 2 RTA. To measure this, you need to measure the urinary osmolar gap. It is usually normal, low in case of the RTA. It is usually high due to presence of an extra acid in the body. So to measure type 1 and type 2 RTA, then you need to know the fractional excretion of the bicarbonate. You will study when you study for the RTA. If you see the metabolic alkalosis, then assess the blood pressure. If the blood pressure is elevated, then it is either primary hyperaldosteronism or secondary hyperaldosteronism or pseudo hyperaldosteronism. If blood pressure is normal, then it is either chronic diuretic therapy, or it is the Barters or Gitelman, or vomiting or chloride diarrhea. This becomes then very simple to measure. To differentiate between Barters and thiazide, as I told you, you need to measure the serum magnesium and urinary calcium excretion. In case of hyperaldosteronism, to differentiate between primary and secondary, you usually measure plasma renin activity. In case of primary hyperaldosteronism, plasma renin is usually low. In case of secondary hyperaldosteronism, both are high. If both are low, then it is called a pseudo hyperaldosteronism. Then it is either Liddle syndrome or the syndrome of apparent mineralocorticoid activity, or it can be Cushing's, etc. So if you see the treatment of hypokalemia, the main thing is to treat the life-threatening complication and replace the potassium deficit. Then is the correction of the underlying cause. The first, always assess the life-threatening complication in your patient. So this urgency depends on the severity of hypokalemia. If it is very severe, for example, if potassium is going less than 2.5, first and foremost thing is correct potassium. If at all it is above 2.5, look for comorbidities. If he is having any, as I told you, organic heart disease, digoxin, the first, it is better to correct potassium. Then see the rate of decline. If the rate of decline is very sudden, then also the emergency management is warranted in your patient. So in managing the hypokalemia, there are some general issues which you should know. The first and foremost thing is the hypomagnesemia, because as I told you, magnesium is to be measured in all patients of hypokalemia and should be treated if deficiently. if deficient. So whenever you're suspecting hypokalemia in your patient, you're sending the laboratory, send the potassium with the magnesium measurement. Then this becomes very, very easy and time-saving procedure. Because if there is hypomagnesemia, the potassium replacement alone may not cure the patient. Then a very important monitoring is required in case of redistribution hypokalemia, because here there is a potential complication of a risk of hyperkalemia as the initial process causing redistribution revolves are corrected. So as I told you, in case of DKA, as there is insulin deficiency and acidosis causing the hypokalemia, as soon as you administer the insulin, more and more potassium is going to secrete out of the cell or into the cell, which can cause hypokalemia. So this acidosis, as it is going corrected, the basic true state is going to appear and can manifest as a hyperkalemia. Such patients can develop fatal arrhythmias also, and the risk is particularly high in patients of the thyrotoxicosis periodic paralysis and the hypokalemic periodic paralysis. Then there are patients with increased sympathetic tone. As I told you, in case of thyrotoxicosis and in case of head injury and theophylline toxicity, here it is better to administer the propranolol, which by blocking this beta 2 receptors can inhibit the movement of potassium into the cell. So in this particular condition, the risk of hyperkalemia is very less. So if you see a patient of the alcohol withdrawal or theophylline toxicity or the thyrotoxicosis periodic paralysis presenting with hypokalemia in your patient, so instead of giving potassium, we can give the propranolol to address the basic cause, as the risk of hyperkalemia is also less in case of the propranolol. And before giving the potassium to a patient, it is better to estimate the total body potassium deficit. Accurately, it is very difficult to predict how much potassium is deficit. However, this estimation definitely helps in preventing the development of hyperkalemia due to excessive supplementation. So there is a chart. If the potassium is 3, then the deficit is 175, and if it is 2.5, 350, and it goes on. But the basic thumb rule is every 100 milliequivalent fall in the total body potassium, the potassium serum potassium falls by 0.27. So 100 fall in the total body potassium causes 0.27 fall in the serum potassium. And if you can also remember the percentage of deficit, for every 0.5 drop in the serum potassium, the percentage drop is 5%. 5, 10, 15, 20, 25. So as I told you, total body potassium is 15 milliequivalent per kg. So you can measure the total amount of body potassium. Then you can calculate the percentage deficit in the patient also. Then after calculating the deficit, then you need to decide which potassium preparation I need to give the patient. There are some types of the potassium preparations are available. Majorly it is potassium chloride, and it is preferred in majority of the patients, because the patients of hypokalemia and metabolic alkalosis are often chloride depleted. So you can, by supplementing potassium chloride, you are correcting both chloride deficit and potassium deficit. And among all the preparations, it rises the serum potassium at a much faster rate compared to the other abnormalities. And it is usually available as a crystalline form, as a salt substitute, or a slow release tablets, or a liquid. Liquid is very commonly available as a pot chlor. You might have heard the name. And similarly, the potassium chloride injection, which is available. Potassium bicarbonate is preferred when the hypokalemia is coexistent with the metabolic acidosis, like the RTA and diarrhea. And if the coexistent hypophosphatemia is there, like DKA, the alcohol withdrawal, the type 2 RTA, Fanconi, so this can be given potassium phosphate, so that you are covering both phosphate and potassium in your patient. And how to treat the mild and moderate hypokalemia. So as I told you, 3 to 3.4, the mild to moderate hypokalemia, this usually produces no symptoms, but you should be careful in some conditions. So in patients with mild to moderate hypokalemia, where the patient is losing this potassium from the GI, as I told you, if there is a metabolic alkalosis, like in vomiting, we can prefer potassium chloride. If there is metabolic acidosis, you can prefer potassium bicarbonate. And the dose here is the 20 to 80 milliequivalents per day given in divided doses. Like it is given either BD or QID. Sometimes you can give as soon as 4 to 5 hourly with the 10 to 20 milliequivalents per day. In case of the renal potassium wasting, what happens if the potassium is losing in the urine? Here, if you give the potassium supplements, the more potassium being given is getting directly absorbed in the urine, directly excreting in the urine. So it will not produce the required response in a patient, especially like if the patient is having diuretic therapy. If you give them pot chlor, whatever the pot chlor you are giving, it's being again excreted in the urine. So that's why these patients are need to be given the potassium sparing diuretics. So these tends to be more effective in case of renal potassium wasting. In hyperaldosteronism, in case of diuretic therapy, in case of the Gitelman, in case of Bartter's, the potassium is usually cannot be controlled just by giving the potassium supplementation. Here, if the patient is having the hyperaldosteronism, then you can choose spironolactone. If the patient does not have hyperaldosteronism, it is some other cause, like if the patient is having RTA, if the patient is having Bartter Gitelman, then amyloid is preferred than spironolactone because of better tolerability with amyloid, as it directly inhibits the neck channel also. So this is the pot chlor syrup. This is a very important syrup which is kept for the viva. So you need to remember the concentration here. Every 15 ml contains 20 milliequivalents. This is a rule of thumb. Every physician is expected to know this. So whenever we give pot chlor, we usually give 60 milliequivalent TID, that is 15 ml TID. This is the usual dose of starting we usually give the patient. Then if the patient is having severe or symptomatic hypokalemia, again, the potassium repletion is most easily accomplished orally. But if it is severe enough, where it requires emergency correction, it can be given intravenously. Because if you give this oral dose, serum potassium concentration can transiently rise by 1 to 1.5 milliequivalents, but only after some time, again, it falls back towards the baseline over a few hours. So if you want to consider the intravenous potassium depletion, there are only some rules where if the patient is having very severe hypokalemia, or if the patient is having symptomatic hypokalemia, if there is a patient presenting with ventricular arrhythmia, you cannot just wait for the oral drug to act. You need to act through the intravenous route. Then in whom the patients, the oral therapy is not being tolerable. Sometimes the oral pot chlor may be very difficult to palate. So patient is having severe vomiting constantly. Then you can consider giving IV therapy. But whenever there is a choice, always prefer oral route better than the IV route. Only in a severely symptomatic patient, like patient presenting with the severe arrhythmias and the muscle weaknesses, you need to consider the IV therapy. Because remember, among hypokalemia and hyperkalemia, it is the hyperkalemia which is much more dangerous than the hypokalemia. Even if you leave the hypokalemia just like that, the patient is may respond with the oral dose. Whereas if you correct this hypokalemia suddenly with the intravenous potassium in causing hyperkalemia, the patient can die in seconds. So IV potassium repletion, before going to the administration, you need to know the adverse effects. The first and foremost thing is the hyperkalemia, which depends on the rapid infusion. If you infuse very rapidly, the 40 to 60 milliequivalent of potassium can result in severe hyperkalemia. Like you cannot give this potassium chloride directly. And inadvertent administration of large amount of potassium in a very short period of time, like when you are given the orders for the nursing staff. So instead of using the infusion pump, they are giving directly as a IV set. So this can cause an inadvertent injection. So they are expected to occur hyperkalemia in the patient. So always it is better to use the infusion pumps in giving the potassium supplementation plus the cardiac monitoring simultaneously. So the pain and phlebitis is a very expected complication during the parenteral infusion of the potassium into the peripheral veins. So this directly depends on the concentration of the potassium in the fluid and rate of fluid. So this usually occurs about 10 milliequivalent per hour. Sometimes it can be seen at a lower rates. So that's why it is always preferred for the large peripheral vein or the central veins, the potassium to be administered. So what is the recommended approach here? So recommended approach is for the GI loss, we are administering the 20 milliequivalents per hour. However, if the patient is having life-threatening hypokalemia, the maximum rate as high as 40 milliequivalent per hour can be given. So if such large doses are required, it should be infused into the large central vein or into the peripheral vein for this patient. So in any 1000 ml of non-dextrose fluid, the maximum amount of potassium that is being allowed is a 60 milliequivalent. You cannot put the potassium above 60 milliequivalent in 1 liter of the non-dextrose fluid. Definitely, we are not using any dextrose containing fluid. There are two fluids in which the potassium should never be given. One is the dextrose containing fluid. Another one is the isolate M. The isolate M is an absolute contraindication due to high inherent potassium concentration in this and the dextrose containing fluid. You cannot mix the potassium chloride in the isolate M and dextrose containing fluid. It is ideally given with the normal saline. So before knowing how to give, you should know how not to give. You should not give above 20 milliequivalents per hour. Per hour, it is not being more than 20 milliequivalents as a rule. And per liter, as I told you, it is 40 or sometimes 60. Per liter, it is 60. And per day, it should not be more than 240 milliequivalents. If at all you are giving about 20 milliequivalent per hour in life-threatening condition, you need to prefer the central venous catheter or a large peripheral vein. So this is a basic understanding of the hypokalemia. This for the potassium replacement in DKA. As I told you, DKA is the only condition where we are giving IV potassium, even the potassium is above 3.3. In the class of diabetic ketoacidosis, I have explained the importance of this study, this in particular amount of potassium. You can go back to the class of diabetic ketoacidosis to understand this. So before concluding a few case scenarios, here you see there is a 32-year-old female who presented with the complaints of generalized fatigue, weakness, and the cramps in the upper limb. There was a history of similar symptoms 5 years back and who recovered spontaneously. On examination, she was found to have a normal blood pressure. There was a weakness in all limbs and there is absent lower limb reflexes. And on examination, she was found to have the hypokalemia and the hypomagnesemia. And on ABG, she was found to have the pH of 7.47 and bicarbonate of 30, that is metabolic alkalosis. So if you see here, there is hypokalemic metabolic alkalosis. So with the normal blood pressure. So ultimately the hyperaldosteronism is ruled out. So, okay, before further going into the urinary potassium creatinine ratio was measured, it is 23.5 milliequivalent per gram. So it is definitely more than 13. So there is renal potassium wasting. So since there is renal potassium wasting with the metabolic alkalosis, the possibilities are either chronic diuretic therapy or hyperaldosteronism or Bartter's or Gitelman or vomiting. There is no history of vomiting. Patient does not have the hypertension to consider it as a hyperaldosteronism. Then option ruled out, considered are here the diuretic therapy and the Bartter's and Gitelman. The diuretic therapy history has not been available. So it is either Bartter's and Gitelman's. So to rule out the Bartter's and Gitelman's, the calcium creatinine ratio was measured. It is very low. So there is an associated hypocalciuria. So since there is hypocalciuria, this is behaving like as a diuretic toxicity. So that is why this is a Gitelman syndrome. So this is actually a pretty simple in case of the case scenarios, whereas in day-to-day practice, it might be difficult. So if you take the another scenario here, there's a 58-year-old male who's a chronic smoker presented with weight and appetite loss since 4 months, presenting with the bilateral upper and lower limb extremity weakness since 1 day, presenting with the hypertension with reduced deep tendon reflexes and the quadriparesis. And the potassium was found out to be the 2.6, and on acid-base analysis, there is alkalosis with a high bicarbonate, that is the metabolic alkalosis. So this patient is having hypertension, hypokalemia, and metabolic alkalosis. So the first and foremost thing is to confirm the renal potassium wasting. The spot urinary creatinine potassium ratio was measured. Then it is found out to be more than 13. Definitely the potassium wasting is done. So since in the background of hypertension, our suspect is there on the aldosterone. So whether to know whether it is a primary hyperaldosteronism or a secondary hyperaldosteronism or a pseudo hyperaldosteronism, we measured the renin aldosterone ratio. The renin is actually low. The aldosterone is also actually low. In fact, renin is normal, aldosterone is low. So this is either a pseudo hyperaldosteronism or the cortisol which is acting like aldosterone. So this can be the inappropriate mineralocorticoid excess. That is, to confirm this, the patient measured the 8 AM cortisol, it is above 50. So the Cushing's was confirmed. To measure the to differentiate whether it is a primary or the secondary to the pituitary, the ACTH was measured, then it is 92, and dexamethasone suppression test was measured. Even after dexamethasone suppression, the cortisol is high. That means the ectopic ACTH was suspected in this patient, and ultimately he was found to have a small cell carcinoma of lung causing ectopic secretion of ACTH, presenting as the Cushing syndrome. So this is a type of evaluation which we usually does in case of patient. So again, an example here is a 58-year-old immunocompromised man with acute invasive sinusitis extending into the brain, who underwent a surgery for the orbital and frontal sinus exenteration. On the culture, he had a growth of the mold along with the Stenotrophomonas maltophilia and the lugdunensis. So to cover the organisms, the patient was given vancomycin, metronidazole, Suptran, Amphotericin, and isoconazole. On the 5th post-operative day, patient was found to have the hypokalemia and the increased creatinine. On ABG was pretty normal. And urine study was done to measure the urine potassium creatinine ratio of more than 51 with fractional excretion of sodium of 2.3. So since fractional excretion of sodium is 2.3, it was a case of acute tubular necrosis with hypokalemia with renal potassium wasting in the background of the toxin drug, that is amphotericin B. So the culprit here is the amphotericin B. Although it can cause the distal RTA, in our particular patient it was normal. Again, the last example here is the case of 45-year-old female presenting with fever, breathlessness, productive cough, with a generalized limb weakness and foreign body sensation in the eyes, presented with hypokalemia and the anion gap of 18. And ABG analysis, she was found to have a pH of 7.26 and 14. So there is a metabolic acidosis and there is anion gap. So there is high anion gap metabolic acidosis. To know the coexisting thing, then we need to calculate the delta ratio, that is the change in the anion gap to the change in the bicarbonate. So here the change in the anion gap is 18 minus 12, and bicarbonate it is 24 minus 14. So it is 6 by 10. So it is 0.6. Since delta ratio is 0.6, the patient is having high anion gap metabolic acidosis plus non-anion gap metabolic acidosis. So in this particular patient, on further evaluation, she was found to have the ANA of 3 plus and anti-ROLA being positive, and her urinary potassium excretion is also very high. So this patient was ultimately diagnosed as a Sjogren syndrome, presenting with the distal renal tubular acidosis with hypokalemia. So if you see some MCQs here, all of the following can cause hypokalemia because of transcellular shift, except beta blockers, insulin, metabolic alkalosis, periodic paralysis. Yes, periodic paralysis can cause, the metabolic alkalosis can cause, insulin can cause. Beta blockers are not the cause of transcellular shift. It is the beta 2 agonists are the cause of the transcellular shift. And hypokalemia is associated with metabolic acidosis in which of the following? They are asking for hypokalemia with metabolic acidosis is associated with which of the following? In case of diuretic use, it is usually metabolic alkalosis. In vomiting, it is also metabolic alkalosis. In hyperaldosteronism, also metabolic alkalosis. In diarrhea, it is associated with metabolic acidosis. So answer is diarrhea. All of the following ECG changes can occur in hypokalemia except ST depression, yes, can occur. Flattening of T wave, yes, it is a rule. Appearance of Q wave can occur. Short QT interval is not a sign of the hypokalemia. Sometimes the QT interval may slightly prolong, or it is usually normal, or a miscalculated QU interval as being prolonged. So short QT interval is a feature of hypercalcemia. It is not a feature of hypokalemia. Then clinical features of hypokalemia include all of the following except muscle weakness, yes, it can occur. Paralytic ileus can occur. Ventricular arrhythmias can occur. Seizures are not the cause of the effect of the hypokalemia. All of the following drugs can cause the hypokalemia except diuretics can cause, Amphotericin B cause, chloroquine can cause, cyclosporin is not a cause of hypokalemia, it actually causes hyperkalemia and hyperuricemia also. Hypokalemia associated with normal blood pressure can occur in which of the following condition? Hyperaldosteronism is a high blood pressure. Liddle syndrome is a high blood pressure. Cushing syndrome is also high blood pressure. In Bartter syndrome, it is the hypotension or the volume depletion. Then maximum concentration of potassium infusion in hypokalemia through the peripheral line should be. So 40, 60, 80, and 100, definitely the lowest value is 40. Then we are going to choose the answer as 40. Although it is 20 for the peripheral, small peripheral veins, but for the large peripheral veins, you can go above 40 milliequivalent per hour or 60. Whereas they have asked per liter here. So that's why per liter it can be up to 60. But it is always better to choose the lowest value according to the Harrison. It is 40. Although per liter 60 it is being mentioned in the up to date, it is better to go with the Harrison. So the answer is 40 here. The rate at which IV infusion of potassium is administered, usually it is the 20 milliequivalent per hour. You cannot give 60 milliequivalent per hour. You cannot give definitely 80 milliequivalent per hour. It is the 20 milliequivalent per hour is the recommended infusion in patient of hypokalemia. So to look at some of the questions here, if TTKG value is less than 5 milliequivalent per liter, then why it suggests hyperaldosteronism? If we administer IV potassium chloride less than 40 milliequivalent per liter, then why pain and phlebitis occur during the parenteral infusion? Why IV potassium chloride is contraindicated in more than 2 milliequivalent? Why the rate of infusion should never occur below 20? So again, the simple, as I told you, the main fear which we have when giving the IV potassium, it is not to develop the hyperkalemia in our patient. If at all you are managing the patient just by bringing the potassium above the existing state, like if the patient is having 2.5 and presenting to you with the arrhythmias, you need not bring the potassium above 3.5 directly. Just by bringing from 2 milliequivalents to 2.5 milliequivalent is usually enough to prevent the development of arrhythmia and coming out of the decompensated state. So this is usually more than sufficient. You need not get the patient away from the hypokalemic state directly. So it can be done over a period of time. So the rate of infusion should be very slow in your patient. During the emergency management, like if the potassium is sometimes the very lowest potassium which I have seen in my life is 1.2 in a case of the RTA, renal tubular acidosis. So these patients are usually chronically hypokalemic. So they are not, this is not an acute hypokalemia which has developed over hours. So the more lower the hypokalemia, it is more slower the rate of infusion should be. Then why potassium chloride is contraindicated is more than 240 milliequivalent. 240 milliequivalent because this is a recommended dose for the 24 hours. If you actually calculate the 240 milliequivalent divided by 24 per day, it comes to 10 milliequivalent per hour. Usually we don't give potassium infusion over a period of 24 hours in any patient. We usually just makes the patient out of a decompensated state, get the patient out of arrhythmias and go on reducing the amount of infusion of the potassium chloride, shift the patient to oral therapy as soon as possible, even with the severe hypokalemia. That's why it is not better to administer the IV potassium more than 240 milliequivalent. There is no condition which requires this amount of potassium in day-to-day life. And if TTKG value is less than 5, high, it is suggestive of hyperaldosteronism. Okay, to understand this, as I told you, TTKG is basically the difference. I'm sorry. TTKG is actually the potassium difference in the lumen and the peritubular capillaries. I'm not able to move the slides here, I'm sorry. So in hyperaldosteronism, as the amount of potassium in case of the lumen is very high, whereas the peritubular capillary is very low. That's why the transtubular gradient becomes very low in case of potassium wasting. And next question is why there is fusion of T and U waves causing long QU interval in hypokalemia ECG. It is not actually fusion. The U wave are going to directly appear at the end of the T wave. And since the T wave is going to flatten and U wave is going to increase in size, they appear to be fused. So this fusion can actually miscalculate the QT interval as QU interval in the patient. So I think I have understood you have understood the hypokalemia chapter in this. So this is very, very important chapter for the practice and for the exam purpose. So many questions are going to appear based on the hypokalemia, the ECGs, and the rate of infusions, the causes, etc. So the basic understanding I think I have given for you. So you need to go and read the textbooks to make perfect, and you need to have a repeated readings to remember all these things at the tip of the tongue, which has been very, very necessary for any physicians. Okay, PPTs I can give you. I think I'm sharing all the PPTs. I have shared all the PPTs till now. This PPT is also going to appear in the Telegram discussion and the WhatsApp discussion with you. So thank you guys.